All right. Well, welcome everybody. This is To Go To Meeting. My name is Manny Parat. I'm a joint replacement specialist at Reconstructive Orthopedics. And today we're going to talk about outpatient hip replacements, particularly hip replacements done at a ambulatory surgical center, otherwise known as a surgery center. So there's a little bit differences about this. And my goal today is to do a very quick overview of hip arthritis, which is probably why you're here. Talk about surgery for it, which tends to be definitive. I'm briefly going to talk about the non-operative treatment. There are non-operative treatment. However, today's discussion will primarily focus on the surgery. I'm going to try to take you through what it means to go through a hip replacement at a surgery center, a little beforehand, like we talked about, going through the actually aspects of diagnosing arthritis, treating arthritis, what it means to have a hip replacement, and then a little bit about the experience at the surgery center. And we operate in Morristown, New Jersey at Vantage Surgical Center. So before I begin, a little bit about me. As you know, my name is Manny Parat. I'm a joint replacement specialist. I grew up in the area. I am fellowship trained. I've been in the area practicing for about 10 years and did my residency and studying also locally in Philadelphia. I specialize in minimally invasive hip and knee replacements. And as you can see today, we are going to discuss hip arthritis. So hip arthritis, unlike most joints that you can palpate or feel, hip arthritis is deep-seated. It is deep within the body. Many patients will experience pain, obviously, or stiffness, including loss of motion. This can be associated with particular movements for hip arthritis, like getting in and out of a car, performing maneuvers like steps or bending over to tie one's socks and shoes. All of those are classic scenarios where an arthritic hip that is quite painful and stiff will talk to the patient and let it know it's there. So unlike knee arthritis, which again is palpable, hip arthritis is often felt deep in the body. The number one area where people experience hip arthritis is in the groin, interestingly enough. It can be on the outside of the hip or what we call the lateral aspect of the hip. It could be down at the front of the thigh, even to the top of the knee, occasionally the buttocks. Pain that travels below the knee is typically coming from an outside source. It's quite common. What's fascinating with all these different areas of the body, many of us will not necessarily recognize that the source, the etiology of the pain is actually the hip itself. So often, very early in the diagnosis, this can be mistaken for a pulled groin, for instance, or a pulled muscle, or sometimes a cramp. When patients have these symptoms, we recommend that you go initially to either your primary care physician, who are often astute and recognizes the early signs of hip arthritis, or an orthopedic surgeon. And here at Reconstructive Orthopedics, myself and 4 other individuals are classically trained at diagnosing and treating all forms of hip arthritis. This can often be diagnosed in your first visit. This can be diagnosed through a history, a physical exam, as well as a basic set of plain films. Often, over 80% of the time, can accurately diagnose hip arthritis. On occasion, you will need to have some further testing, sometimes some further imaging, but this is typically not the norm. As previously mentioned before, hip arthritis is often treated, like many or different arthritises, conservatively at first. We often will prescribe patients rest and activity modification, staying away from egregious exercise that can bring about these symptoms. NSAIDs, or non-steroidal anti-inflammatory drugs, are often the mainstay. These are medications like Tylenol, ibuprofen, Motrin, sometimes aspirin. On occasion, when they're insufficient to control one's symptoms, we can often prescribe an injection. So let's dig a little bit further into the anatomy of the hip. We're going to focus on the joint itself. As you can see from the slide, a healthy joint is made up of the ball, which is the top of the femur, which is the thigh bone, and it articulates or moves on the inside of the socket portion, and that is called the acetabulum, or the smaller portion of the pelvis. And so it is truly a ball and socket joint. These two bones are cushioned as you're born, for most of us, with articular cartilage. This is a very slick substance that allows these two bones to maneuver against each other softly and without any friction that can cause pain. Arthritis typically happens after the age of 50. It typically involves a wearing of the cartilage, and this undermines the cartilage to expose the bone underneath. The bone rubbing against the bone can cause this stiffness and pain and swelling that people will often feel. And again, it is typically a disease of attrition, meaning it occurs over time. It is typically in patients over the age of 50, as well as those who have a family history is quite common. So if we dive directly into the surgery itself, what is the goal of the treatment of surgery? Well, it's fairly straightforward. The goal would be to remove the two bones from rubbing against each other. The thought process is that by doing so, you can remove the offending agent, the source of the pain, the stiffness and swelling. Surgery entails a dissection down to the bone, removing the portion of bone that is, again, arthritic and loss of cartilage, and placing it in instead with a metal spike, often known as a femoral component. It typically has a femoral head on it that moves against an inside new-bearing surface. Often in America, we use a very finely piece of polished plastic, and then that is based in a cup or acetabular component, and that is placed within the shell. So a more definitive look at this will actually show you that these components are modular, meaning that they come separately and they can be linked together, much like modern day Legos. And that means a lot to you if you have kids like me who leave the Legos around, which are often painful on my feet. These components, like we talked about, the femoral stem, the ball that is typically made out of ceramic component, and the socketer lining are used to establish a new ball and socket for patients. And many different companies throughout the years have made various different models of these. Currently, the components are slated to last greater than 2 decades, or anywhere between 20 and 30 years. Which is quite common no matter what the surgeon chooses for a company. Okay, so this type of surgery has been going on for 6 decades. The modern day hip replacement first kind of originated in England and then was brought over here to America by a famous surgeon named Sir Charnley. And he was actually performing this type of surgery in the 1960s. The surgery has changed somewhat since then, and today's total hip replacement is often utilized or performed utilizing a minimally invasive approach, or MIS, minimally invasive surgery. And that can mean various different things to both surgeons and patients, but overall it generally means a smaller incision, a reduction or elimination of the muscle dissection. This can be performed robotic assisted, and often component placement is pre-registered for the surgeon to allow ease of insertion. All of these different type of scenarios that go into minimally invasive approaches or surgery are used for the patient, for the benefit of the patient, in order to improve early recover and make a faster return to activities that the patient wants to do. The surgery is quite common. Although not as common as total knee replacements, like we talked about, it's been performed in the world for probably at least 6 decades in its modern day form. And the projections for this type of surgery are drastically increasing. As the population in America ages, we're actually becoming more active, not less active. And so what we find is that the projection for this type of surgery is going to wildly increase. And if you see the slide above, you can see that these numbers are in the hundreds of thousands throughout the years. And this shows you over the last, I would say, a decade and a half or so of how hip replacements are projecting. And so total hip replacements, and if you add in total knee replacements, are going to increase to about 4 million type of procedures in the next decade, which is a lot to say the least. Okay, so currently, where is the state of total hip replacements? Currently, the traditional joint replacement, total hip replacement, is performed still at a hospital. This is a traditional approach. It's typically done where patients are set up. They see their surgeon. Surgery is set up prior to the hospital stay. Typical scenarios are patients get laboratories and radiographs and are often discussed on what to anticipate during the hospital stay. And again, this is typically done at your local hospital. We operate a Virtua Voorhees to be specific. And a stay can be anywhere from 23 hours to all the way to 2-3 days, pretty common. Having said that, since this has been going on for years and years, we have studied and found that patients who are typically struggling and stay in the hospital for longer than 72 hours often have a higher rate of actually returning to the emergency room for issues either related to the surgery or completely unrelated to the surgery itself. So we are greatly concerned about extended stays in the hospital, for particularly, I think, very poignant in today's society. There are strong concerns for both viral and bacterial infections that we would like to try to mitigate or prevent. So having said that, this brings us to surgical centers. Ambulatory surgical centers have been developed years and years ago, and the initial onset in America was to try to offload surgeries or daytime surgery that were performed in hospitals. This would improve hospital efficiency, decrease cost, and what we found is that for various different surgeries outside of joint replacement, patient satisfaction was actually higher, not lower, when performed in a surgery center. They are efficient, safe environments. And so over the last half decade to decade, joint replacement surgery has been investigated and introduced into the milieu, into the environment of this surgery center. It was able to do so because we were able to finely tune protocols for predictable discharge. Issues like blood pressure, oversedation, urinary retention, and nausea, vomiting. These were all issues that commonly patients experienced during the hospital stays that we noticed would cause them to stay longer. And so they are now actively being mitigated to help reduce, again, hospital stays, but more importantly, try to establish a scenario where patients can have these surgeries done at a surgery center. So operating in the morning and leaving back to your house either at lunchtime or before the evening. I will often get asked questions as an outpatient when I see patients, who's a candidate? Who's a candidate? And what I would like for you to take away, if you take away anything from today's session, is that I want you to think of yourself as a candidate. So patients who have decided that, most importantly, that they want to pursue surgery and they agree with their surgeon's initiative that this is beneficial for them, you should think of yourself as a candidate with some minor exclusion criteria. So exclusion criteria would include severe cardiac or pulmonary disease, severe kidney dysfunction, a history of a potentially cognitive dysfunction or issues following and potentially some issues with voiding that require catheterization more commonly, and severe mobility disorders. Outside of these, I truly want you to take home today's talk as you should see yourself as a prime candidate, a good candidate for a total hip replacement done at a surgery center. Not only is that the truth, but what we're finding is that outcomes are better, and the patient's experience is certainly improved. So speaking of experience, what is that going to look like? What does it look like? And I get that a lot because it is a fairly new scenario for patients to think about a major surgery, like a joint replacement done in a surgery center. So the surgery itself, your experience would start very similar to that as an inpatient stay, And what that would include is preoperative laboratories, a discussion with your surgeon, and radiographs, potentially additional imaging if it's so necessary, and and clearances. Very important is that many patients will come with a pre-existing medical history, and we want the surgery to be done safely and fine-tuned. And so our office at Reconstructive Orthopedics will help schedule all of these laboratories and different findings for you. Our office is open early and late, and the joint replacement staff has a fine, well-tuned machine that will allow you to experience a very linear scenario where these outpatient appointments are set up for you. Like we said, we operate out of Vantage Surgical Center, and this is located in Morristown, New Jersey. And so one thing I think I would be remiss in saying is that this is a brand new state-of-the-art facility. The patient rooms are brand new. They are cleaned. They are terminally cleaned after every patient comes in. They have modern day equipment. It has a modern day feel, up to date. And most importantly, I think for the patient is that the surgery rooms themselves are brand new. They include the capabilities of performing not just total hip replacements with and without robotic assisted devices, but the overwhelming majority of cases performed in orthopedics today. The experience will start early. So much like myself, I hope you are an early riser. I would expect the surgery to initiate or start around 7 in the morning. So often I would plan at being in the facility even earlier, depending upon where you live, potentially even an hour or even earlier than that. You will talk to the anesthesiologist team, wonderful and very experienced, we've been doing this for several years. Currently, they will talk to you about spinal options. So what we're recommending and finding success with, as is the literature, is showing that a light spinal anesthetic is augmented with a regional block, meaning that you are made numb from your belly button down to your toes for about 2-3 hours. The surgery is performed, and within an hour or two after being in the postoperative care unit, you will find that the anesthesia wears off and you are mobile. We are proactive during these cases. We try to limit blood loss. We try to limit nausea, and you will receive all sorts of medications, including some steroids known as dexamethasone and tranexamic acid to reduce blood loss and nausea. As we discussed before, those are two primary issues with trying to get patients up and early. We have eliminated all drains. We've eliminated all catheters. There will be no lines in you. You'll be up and freely moving as soon as you are capable. We're going to employ a multimodal pain protocol that tries to limit oversedation with narcotics. In its place, we are going to augment pain relief with a multitude of different medications, including Tylenol, COX-2 inhibitors, often known as Celebrex, gabapentin. Very popular in the literature is early mobilization. What we have noticed is that getting patients up and early and employing ice very, very early has dramatically decreased both swelling and pain. So patients are able to walk and move within an hour or two even after the surgery is done and preparing to go home. What does discharge look like? This staff, particularly the nursing staff, who are just absolutely fine-tuned and wonderful as Vantage Surgical Center, have distinct criteria. Patients need to have reasonable pain scores under 5, dry wounds, demonstrate independent transferring, mobilization with either crutches or walker, and preoperatively, a safety plan at home will be established for you, typically when you're seen in the office, and we will go over exactly what it means to have a patient advocate, make sure that your preoperative medications and that your plan for physical therapy and that resources are well taken care of. These are rapid replacements. So let's look at what's been going on. As we discussed, total hip replacements in a surgery center have been being performed for the last half decade or so. And in the last year, we have been able to quantify some of the results. So these surgeries take less than around 2 hours or less even to completely perform. That's from the time you go in. And what we have noticed, both in our experience as well as that complements that of the literature, is that we've had 100% ability to discharge patients directly to home. So one of the main concerns is that patients are fearful that they won't be able to go home. I think the previous experience from our institution and many others demonstrates that, this is certainly possible with a wide range of patients, and try to assuage some of those fears beforehand. This is something that's here to stay, And what I mean by that is about a half decade ago, like we talked about, around the country, 25 ambulatory surgical centers were used as kind of test sites, so to speak, and looked into very, very strictly on who is able to have an outpatient total hip replacement and how successful it was. And as you can imagine, it has just skyrocketed from there. 3 short years later, in 2017, over 200 ambulatory surgical centers around the nation are performing this surgery. And rightfully so, outside of the wonderful experience that patients are getting, what we've often seen is that this is a fairly significant decrease in cost to both the healthcare system at large, the local hospital system, and hopefully that will trickle down to patients themselves in the future. Here to stay, like we talked about. I truly believe, and I think if most patients look into total hip replacement as an outpatient, this is the future, truly the future. So what you will find is that the performance of these joint replacements in outpatients is expected to rise significantly. In fact, in a short matter of just in the next 6 years, I think what you'll find is half the replacements in America will be formed as a surgery center. I know personally, we've been trying to get to that spot pretty rapidly, and I am confident with the plans that are set in motion very recently, we will be able to meet these goals of 50% of the joint replacements being able to perform at a surgery center way before that 6-year mark of 2026. However, I don't want to focus on that. I'd like to make sure that patients understand this is not only in the best interest of society at large, which are those important, patients are very happy with the scenarios. In very recent studies, as short as just a year or two ago, we have actually noticed that over 80% of the patients, and sometimes even as far as 96% of the patients, that they would choose to have a total hip replacement done as an outpatient in a surgery center. Not only again, but satisfaction scores were actually higher. Satisfaction scores were actually higher from those performed in the hospital setting, which I think is very, very telling of where this procedure is going. Now, I think I'd be remiss if I did not address the major concern that all of us are experiencing, and that is obviously the COVID-19 pandemic. So this is taken very seriously. This is taken very seriously by Virtua, by reconstructive orthopedics, as well as your joint surgeons at large. So we have instituted several policies, both for the safety, most importantly for the safety of the patient, but also for the safety of the staff. And these are issues that will be ongoing. They are very fluid. They're very fluid. The news cycle and information from COVID-19 changes daily. In fact, sometimes it's even difficult just to keep up with it. But you know, I want patients to understand that these are fluid changes. One, two, that they are implemented for your safety, for the safety of you, for the safety of the surgery, as well as the people around you. So having said that, all patients that will be going for a total hip replacement, and actually even beyond that procedure, will be tested, must be tested for COVID-19, despite if they're symptomatic or not, within 72 hours of the surgery itself. And we will help set that up and schedule it for you. Patients will be informed of their status, either negative or positive, before that they come to the surgery center. There will be a strict social distancing policy with masks, both in the waiting area, in the preoperative area, as well as the postoperative area. Very important for us to understand that we need to continue social distancing in order to try to protect patients. Family members are going to be encouraged to wait in cars. Certainly, this is you know, something that patients have or family members have done routinely. But they will be in contact. Hopefully they will have cell phones available. If not, we certainly can take down numbers to call when for updates on how patients are doing. I think not only is it important for patients to be screened, but I think it's important for patients to understand that as seriously as we take it, the staff will also have these rules mandated. All staff will have recorded temperature checks daily. We will have the ability to contact trace and quarantine if necessary. Patients will be encouraged to have short-acting anesthesia, as we mentioned before, and depart from the postoperative care unit as early as possible to return back to your safe environments at home. We've also understand the staff will extend hours. We are going to open slightly earlier and stay open slightly later in order to space patients to try to implement social distancing and make it easier for patients to separate themselves. So having said that, although all of those are going to happen at Vantage Surgical Center, many of those aforementioned updates will actually be implemented throughout the Virtua system. And again, this is fluid and changing, and you know, we are simply adapting to the environment. So at this point, this concludes my talk. I hope you found it interesting. I hope you have some questions for me. I'm available, and thanks so much for tuning in.
Thank you again, Dr. Pratt. That was great information. Like he mentioned, we'd like to open it up for questions now. If you want, you can type them in the chat box, or if you want, you can unmute yourself, just as long as we don't have multiple people talking at the same time.
May I speak?
Of course.
I understood from the title that this was supposed to be on hip and knee replacement. Are you going to cover the knee replacement?
Yes. So there were some overlap. Our actually pre-recorded discussions have knee replacements in them. And today I just focused on hip replacements, as I didn't want to try to shun my partners from speaking. So today we're just going to focus on hips. But we have a whole flurry of talks, both previously recorded on knee replacements and upcoming in the future.
How can we find out when they are?
A great question, Cece.
Yes. So Dr. Jane, last week, I believe he did a video on outpatient knee, and I believe he included hip as well. If you visit our website at www.reconstructiveortho.com and you go to patient resources, there's a button there for the video library, and his recording is on that list there. All of the recordings from all of our talks are in our video library.
I hope that answers your question.
Were there any other questions?
All right. Well, thank you for tuning in.
Yes, thank you again, Dr. Peratt, for your time. And I want to thank everybody for joining us. And we'll go ahead and end this.